Hello friends, welcome back to my channel with a new video, and this is a part 2 of arterial blood gas analysis which we left last time. And just to kind of brush up, we started with the validation. We discussed the steps of validation. Number 2, we had that understanding of the clinical context, which is so very important to analyze ABG. Then we had a flow chart of the approach to the hypoxia on ABG, and then we had how to actually know whether which is the primary disorder. So just to kind of revise, and this is I thought the most important slide, that if you have a pH and the bicarbs going in the same direction, this is a primary metabolic disorder, and pH and the PCO2 going in opposite direction, then this is the primary respiratory pathology. Let's move on. So the next step, if it is a primary respiratory disorder, whether it is acute or chronic. Now for respiratory, it can be either respiratory acidosis and or respiratory alkalosis. So as far as respiratory acidosis is concerned, as we know, with every 10 increase in the PCO2, there will be compensation of bicarb, which will increase, because if the acid is increasing, the base also has to increase. PCO2 actually is an acid, so the bicarb will go up, and it will be acute and chronic. So remember, with every 10 increase of PCO2, the bicarb will increase by 1 if it is acute respiratory acidosis, and bicarb will increase by 4 if it is chronic respiratory acidosis. This is very important. So on the contrary, if it is respiratory alkalosis, when the PCO2 will decrease by 10, the bicarb will also decrease, and here also we will have either acute or chronic. So the formula is, for every decrease of PCO2, there will be bicarb which will be decreased by 2 in acute, and bicarbs which will decrease by 5 in chronic. So we actually remember the figures as 1, 4, 2, 5. 1, 4, 2, 5 for acute chronic, respiratory acidosis and respiratory alkalosis. So this is how we remember. So if actual bicarbs are more than expected, then there is additional metabolic alkalosis, and if the actual bicarbs are less than expected, there is additional metabolic acidosis. This brings me to kind of give you a very important message, that in arterial blood gas analysis, there is no overcompensation. There is no overcompensation. So if it is either, it could be undercompensated or compensated. And remember, if there is anything which is overcompensated, there is a mixed disorder. Okay, so this don't forget this statement. So next step is to know whether there is appropriate respiratory compensation for a metabolic problem. Now as far as metabolic acidosis is concerned, what are we interested in calculating is expected PCO2 as a compensatory mechanism, isn't it? And this particular formula is called as Winter's formula, which goes by 1.5 multiplied by the bicarbs plus 8 plus or minus 2. So this is a very standard and a very famous formula which you should not forget. For metabolic alkalosis, the expected PCO2 will be, in easy way you can remember, 15 plus bicarbs. That's it. So it's very easy to remember. Okay, so for metabolic acidosis, it will be predicted PCO2, which is given by Winter's formula, that is 1.5 times bicarbs plus 8 plus or minus 2. And for metabolic alkalosis, expected PCO2 will be 15 plus bicarbs. That's it. And we have already discussed that there cannot be overcompensation as given by these two statements. Now there is something called as compensation limit. So for metabolic acidosis, the PCO2 can be up to 10. For metabolic alkalosis, the PCO2 maximum can be 60. Similarly, for respiratory acidosis, the bicarbs can be maximum of 35, and respiratory alkalosis, the maximum bicarb could be up to 15. Following this, especially in the presence of metabolic acidosis, we need to calculate something called as a anion gap. So it is nothing but the difference between the measured cations, that is sodium and potassium, and the measured anions, that is chlorides and bicarb. So the anion gap formula is given by sodium plus potassium minus chloride plus bicarb, and the normal range is between 10 to 12. Remember, if the potassium is included, then add 4 to normal range. So this becomes 12 to 16. So if you calculate anion gap by the formula of only sodium minus chloride plus bicarb, then it will be 10 to 12. Whereas if you use this formula, sodium plus potassium, then it will be around 12 to 14, 12 to 16. Okay, because negatively charged plasma proteins account for the normal anion gap, the normal value should be adjusted downwards for the patient with hypoalbuminemia. So remember, anion gap corrected for hypoalbuminemia is equal to anion gap plus 2.4 multiplied by 4 minus patient's albumin. So this is the corrected anion gap for hypoalbuminemia. So I think you should remember this particular equation and the range of 10 to 12 if potassium is not included, and of course if it is included, then it will be 12 to 16. Now this is there are various mnemonics to remember what are the causes of high anion gap metabolic acidosis, or classically called as HAGMA. And as you could see in this particular mnemonic, it is CAT, mud, piles. So it stands for CAT, stands for carbon monoxide, cyanide, congenital heart diseases, aminoglycosides, theophylline, methanol, uremia, diabetic ketoacidosis, alcohol ketoacidosis, starvation ketoacidosis, paracetamol, fenformin, paraldehyde, INH, inborn errors of metabolism, L for lactic acidosis, ethanol, and S for salicylate or aspirin. So CAT, mud, piles. Similarly, for normal anion gap metabolic acidosis or NAGMA, it is hard up. So H for hyperalimentation or starting of TPN, A for acetazolamide use, R for renal tubular acidosis, D for diarrhea, U for ureterosigmoid fistula, and P for pancreatic fistula. So this is hard up. Now the next step, as if you could remember in our list, there is something called as a delta gap, and it is nothing but also called as gap ratio, and the formula is given by anion gap minus 12 divided by 24 minus bicarbs. So this is a simple formula, and you can just see that formula and remember it in your mind, that how to calculate the gap ratio. Again, there is a ready reckoner of if the delta ratio is less than 0.4, then it is hyperchloremic normal anion gap acidosis. If it is less than 1, it is high anion gap plus normal anion gap. If it is between 1 to 2, it is either a lactic acidosis or diabetic ketoacidosis. And if it is more than 2, the high anion gap acidosis and a concurrent metabolic alkalosis or a pre-existing compensated respiratory acidosis. So a gap ratio at these values will correlate with a proportional kind of clinical scenario. Okay. Now there are various causes of metabolic acidosis, alkalosis. So they are either a GI acid loss, so that is vomiting, or excess of bicarbs, as in case of increase in the soda bicarb, IV, post hypercapnia, or milk alkali syndrome. There can be renal acid loss like primary or secondary hyperaldosteronism, Bartter or Gitelman syndrome, diuretics, or hypokalemia and hypomagnesemia. Either it can be seen in laxative abuse or contraction alkalosis in the form of diuretics. So these are the causes which you should be aware of. Similarly, these are the causes of respiratory acidosis. Like, we are actually encountering a patient of hypoventilation. So like acute intoxication with narcotics or sedatives or opioids, severe metabolic encephalopathy, obesity hypoventilation syndrome, severe COPD, acute upper way obstruction, neuromuscular disorders like GB, the Guillain syndrome, or myasthenia gravis, or botulism, later stages of severe asthma, thoracic cage trauma or flail chest, or inappropriately low minute volume setting on mechanical ventilation of the, or if there is a leak, or if there is a blockade of the HMEF or the endotracheal tube, all this will cause hypoventilation. The causes of respiratory alkalosis are early stages of acute asthma, exacerbation, anxiety, pain, acute hypoxia, pregnancy or other cases of elevated progesterone, cirrhosis and hepatic encaph, salicylic intoxication, the central nervous system disease, and overventilation on mechanical ventilation. And just talking about the osmolar gap, whereas we know that it is nothing but the difference between the measured osmolarity and the calculated osmolarity. And the calculated osmolarity can be given by the formula of 2 multiplied by sodium plus glucose divided by 18 plus BUN divided by 2.8, and a normal osmolar gap is less than 10. So these are the causes of high osmolar gap like mannitol, methanol, ethylene glycol, sorbitol, IV lorazepam, diazepam, or phenytoin, the glycine, or a TERP syndrome, and maltose. So these are all the causes of osmolar gap. And coming to the urinary anion gap, where we know that it is nothing but the urinary sodium plus urinary potassium minus urinary chloride. And urinary anion gap was proposed as a tool to differentiate between GI and the renal causes of hyperchloremic metabolic acidosis. So if you encounter a patient of hyperchloremic metabolic acidosis, you need to differentiate whether the cause is GI or renal, and for that we need to calculate this. So interpretation, if it is negative or a low urine anion gap, then it is mainly gut. So you can remember by this negative or negative. So this is gut, and no change, it will be renal loss. And if it is positive, then it is altered urinary acidification or renal tubular acidosis. So I think this is what we are probably looking at. And the normal anion gap acidosis, where we actually see the renal the urinary anion gap, whereas we know that if it is positive in renal tubular acidosis and negative in diarrhea. So if it is urinary pH of more than 6, it is type 1 RTA. Urinary pH of less than 5.5, it is type 2 RTA or type 4 RTA. And hyperkalemia, it is type 4 RTA. So this is how I have actually tried to look at the ABG in a comprehensive fashion. I hope all these steps will help you to kind of analyze the ABG in a correct fashion without missing on any step. And I'm very sure that I have not left out anything as far as even for the DrNB students or DM students appearing for exams. That's all for now. Take care of yourselves. Bye bye.